would like to introduce our next speaker, Dr. Yelena Novik, who is an associate professor in the Department of Medicine here at Perlmutter Cancer Center.
Okay, welcome everyone. As you know, as you have heard, San Antonio is our Mecca, and we go there yearly to see each other frequently, but also exchange information and what seems to be the newest things that happen in breast cancer. So I tried to come up with kind of the topics that caught our attention, me as a medical oncology doctor who specializes in treatment of breast cancer, and trying to find one topic for a particular subtype of breast cancer. As we know, there are many that kind of change a little bit the trajectory of how we treat this particular disease, or at least became something which is important. Is it changing our practice or making direction of how we look at it? And so I will separate my kind of talk into particular topics. If certain things may not be fully recognizable, please interrupt me. And the first part, we will talk about the so-called HER2-positive disease, and some of you may be very familiar, some of you may not. HER2-positive disease, approximately 20% of breast cancers, and it is a particular type of breast cancer that we now have a lot of different drugs with. But in the San Antonio trials, in the San Antonio meetings, there was a particular trial presented that, so we knew it was finished and we kind of were anticipating results, but we didn't know how much these results would be interesting and how much eventually they would change their practice. So let me tell you about what's called Katherine's study. Yeah, we do like very fancy, preferably women's names for our clinical trials. So Katherine's study was their randomized study, and we like randomized studies to really prove our points because that's how we can do so. It was really designed for women who presented with palpable, what we call locally advanced HER2-positive breast cancer. And usually we do treat this women upfront with chemotherapy and anti-HER2 therapy. Some of you may have heard the name of the drug Herceptin. That's usually a part of this regimen. And after they finish this type of treatments, they do get surgery and frequently radiation, with Dr. Perez, who's my colleague. And after they do that, they usually do get the rest of the year. They received also continuous treatment with a medicine which is called Herceptin. Herceptin is so-called monoclonal antibodies. That's the kind of pride of our profession over the last 15 plus years. We've been using these biologic drugs with a lot of success to treat disease. But the question for this particular study was whether if introducing at the time after surgery, whether during radiation or after, another drug, which is a fascinating product of the geniuses of pharmacology, which combines in the same molecule the biologic drug and the chemotherapy drug. And this drug is called TDM1, or some of you may know this under the name of Kadcyla. Again, some of the names of our drugs may sound very fascinating, but the results will be much better. And so this study was going for quite some years, for a couple of years. And this is really kind of their topic of very important advantages, because if you think about for HER2-positive breast cancer, their breast oncology made a tremendous improvement. If you look back, that Herceptin was first originally approved in 1987 for metastatic disease, and then in 2005 it was approved for adjuvant disease. I know for some it may look like it was centuries ago, but before that we didn't have any monoclonal antibodies to treat breast cancer, and these women died uniformly from that disease, and now we have so many drugs and can do it better. But even with the regimens that we had before Katherine came around, the study found that there was almost decrease in 50% decrease in recurrence in the patients who received this drug TDM1, or as I said, the commercial name is Kadcyla, after surgery compared to Herceptin alone. So the 12% recurred in the TDM1 arm versus 22 in the traditional arm, which is a Herceptin arm. This is what in our statistical language represents a hazard ratio of 0.5, which is a really, really big improvement. So that's a half of their improvement, and the overall survival in the study was a 10% improvement with the new drug. Just to let you know, the new drug, which is called TDM1 or Kadcyla, is approved currently for the treatment of what we call metastatic or advanced HER2-positive breast cancer. So the drug's been available commercially for the last 6.5 years, maybe 7, if time flies very quickly. But this will be now the first really advance of this drug in what we call early stage breast cancer. And that will be another significant improvement when we look at this population of patients. That will a significant improvement, almost 50% improvement in the chances this disease will recur again. So for many of us who treat breast cancer with different medications, so we left San Antonio with a very new meaning that for the patients who have HER2-positive breast cancer and present with the large tumors, if after chemotherapy before surgery, they do have residual disease, we do have some new agents for our patients, that may again significantly improve the chance for these patients to stay cancer-free, and we have, more options for these patients. So that was a really very positive meeting. So the second was kind of a very interesting question, and I still think very controversial. So that was probably one of the most exciting, so kind of frivolous a little bit subjects on this San Antonio. And I think some things that probably Freya will agree with me, something we hear, maybe Carmen agrees less, I hear maybe 10 times a day, can I please take tamoxifen for a shorter period of time? Can I take it every other day? Can I take a less dose, etc.? And I always say, well, we don't know the answer. The only way we studied tamoxifen is by giving it 20 milligram every day for 5 years, and we do not know better. We wish we could. And let me tell you, some very brave Italian surgeons decided that they will try something like this. So they did a study in a few community oncology centers, and they took 14 centers in relatively smaller, cancer centers, breast centers in Italy, and they took 500 women with high-risk conditions. So they were not breast cancer, they were high-risk conditions. So LCIS, atypical ductal hyperplasia, and DCIS. And they took low-dose tamoxifen, standard dose tamoxifen, and placebo. And they treated patients with this for 3 years, again, versus our traditional 5. And the study was found to be so interesting that it was presented as a plenary session of San Antonio. And their low dose of tamoxifen for 3 years produced the same 50% reduction in development of invasive breast cancer as our traditional dose of tamoxifen does, which is at 20 milligram every day for 5 years. There was expected toxicities in terms of, thromboembolic events and endometrial cancer that were kind of proportional to what we usually expect, but their risk reduction was very similar, again, in the range of 50% that we do see with traditional tamoxifen dose. I think that was very interesting for everybody to see. The question was, anybody will want to reproduce this in a larger study? I think is a bigger question. But I think at least for those of us who want some answers and some justification whether a lower dose can be still effective, we have some data of a randomized, albeit small study, suggesting for the high-risk patient there may be some data. Since this was a very important piece of information looking more at their kind of epidemiology of breast cancer, some of you may have heard about the Tailorex study. Tailorex study was a very large study that was conducted over 9 years, close to 10. It was presented within the previous year and looked at the use of a genomic signature, which is called Oncotype, to predict and kind of certify the benefit of a particular type of adjuvant or adjunct therapy, whether the use of chemotherapy will be beneficial in addition to hormonal adjuvant therapy. So Tailorex was a national and international study. The whole of the United States participated, including us. We were a larger crew to that. Some foreign countries participated as well, Ireland, Peru, and some others. And the study was really concluded, showing us how Oncotype can very well predict whether the patient's cancer have a lower chance of recurrence and whether hormonal therapy will be adequate treatment and chemotherapy can be avoided. But in this, there was approximately 12,000 patients treated on this trial. So it's also provided a huge volume of data on women treated for breast cancer with more or less the same stage and followed for many, many years. And I think this piece of information was presented at San Antonio, which I think doesn't give us answers, but continues puzzling us. So what investigators from the Tailorex group, it was, representative of all large cooperative groups, so basically big researchers in breast cancer throughout the country, that continued to look at racial and ethnic differences in women with breast cancer. And so they saw no differences in what we call recurrence score. And if you know, it's a measure of this genomic complexity in breast cancer among women who were Black or Hispanic or other groups. In spite of this, and in spite of the fact that all women in different racial or ethnic groups received the same type of chemotherapy or hormonal therapy, their outcomes were still significantly worse for African American population. So we're not really significantly different for Hispanic population. So in the intermediate group that seemed to benefit from hormonal therapy for all groups the same way as the lower group, there was significantly higher risk of recurrence in Black women compared to white women, as well as significantly higher risk of deaths. Which at least tells us again that we probably, as much as we understand the genomic predictors when it comes to separating who needs chemotherapy, who needs hormonal therapy, and how to treat them, it may not be enough for us to understand also the character of breast cancer when it comes to different ethnic groups and how we can work with them. There's probably still quite a lot of limitations to what we know and how we can work with them and what other parameters define this. But I think it's their significant importance of data. And so we talked about HER2 positive disease. We talked about estrogen positive disease, right, in a high risk group. And now it's important to say about triple negative breast cancer, which is another subtype of disease. And I think we also want to be, very important because we'll talk about a trial which was presented there which we also kind of have relationship with because one of our colleagues was one of the main investigators on this trial, and this trial now led to FDA approval. So triple negative breast cancer is a type of breast cancer that doesn't have estrogen or progesterone receptors or expresses HER2. That's why we call it triple negative. But we also do know that traditionally it does have a so-called poor behavior and cannot be treated with traditional targeted drugs such biologic drugs as anti-HER2 drugs or hormonal drugs. And in the past, we had only chemotherapy to treat these patients with. But over the last few years, since so-called immune therapy became such an interesting possibility for many cancer patients and became standard for patients with other malignancies such as melanoma or kidney cancer or lung cancer or other diseases, that for the triple negative breast cancer that really became a possibility. So the IMPASSION trial was really a trial that was driven by so-called immune markers, and it's specifically for patients with tumors that express this particular marker. And all patients received chemotherapy with chemotherapy drugs, which is called Abraxane or nanoparticle Taxol, and they were randomized to chemotherapy to receive atezolizumab, which is anti-PD-L1, or immune therapy or placebo. And when this data was analyzed and presented, the patients who did receive immune therapy, and if they had expressed this particular biologic predictor to success of immune therapy, they had a significantly higher chance of surviving surviving longer. So the median, what we call survival time the patients live, was 25 months versus 15 months in this category. And proudly enough, the FDA, which is Food and Drug Administration, which is our main regulatory body for this whole country, just approved, based on this particular trial, the drug atezolizumab, which is commercially called Tecentriq, in combination with chemotherapy for patients with triple negative breast cancer. That's based on exactly the IMPASSION study that was presented in San Antonio. So this is the first approval for immune therapy in breast cancer, and specifically in triple negative breast cancer, which is definitely opens this opportunity for the patients who otherwise were limited only to chemotherapy. So it's again the news that came from San Antonio, the Mecca for breast cancer, and really enriched possibilities for our patients. That's pretty much all I wanted to say.
Yeah.